Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
I will be talking with you all today about some of the data that we have been able to amass on the importance of starting antiretroviral therapy for people who have acute or early HIV. I should just say it's not on my slide. Here I'm defining acute HIV. There's various different definitions. Some people say within 30 days of estimated date of acquisition. Some people refer to acute HIV as being seronegative. I'm using this loosely, I think, and we'll use it here most kind of along the lines of either seronegative or within 30 days. And then early HIV we're defining in this study as within 3 to 6 months. So people who don't meet any of the sort of standard acute definition. So that's just kind of some ground setting as we move along. So prior to this study that I was involved in, which I'll just mention was performed in Lima, Peru, I'll talk a little bit about it, and was a collaboration with the Fred Hutch. We have known that globally antiretroviral therapy has been considered important and recommended on diagnosis regardless of pretty much any other clinical or demographic criteria, with a very few exceptions like active TB meningitis or cryptococcal meningitis, for example, for everyone living with HIV. Most of this data has come from people who were studied with prevalent HIV, which I'll define as infection of an unknown or long duration. So essentially people who aren't necessarily in acute or early HIV. And most of these studies and most of the antiretroviral therapy initiation criteria has been stratified by CD4 count historically. So first we were treating people below 200, then below 350, then up to 500. And then some of these newer studies, I'll say the studies that sort of set the current standard, were called Insight Start and Temprano, both published kind of as companion papers in the New England Journal in 2015, that really set the stage for saying that we really saw individual health benefits in terms of prevention of non-AIDS morbidity and mortality in starting with people at any CD4 count. But again, these are people with infection of unknown duration, some that may be short duration, some might be longer duration. So there isn't really any data on the individual health benefits of starting treatment in acute or early HIV outside of a few kind of non-randomized special cohorts that collected this. And these mainly looked at inflammatory outcomes in HIV reservoir as well. We do know that there's a very strong rationale for treating people with acute and early HIV for treatment as prevention or TASP, because obviously these are many people who don't know their status and often transmit with high viral loads in the time period before they become aware of their own diagnosis. And so they're potentially not using preventative measures because they don't know their own status themselves and they have a high kind of force of infection with a high viral load. So, public health benefits have been proven for this, and then we're looking here at kind of the individual health benefits in this study. So this study was called Sabes. Sabes means in Spanish, do you know? So it was about, do you know your status? And it was really designed as sort of a TASP study to look at the benefits of, is there a public health benefit of trying to detect acute HIV and get people on immediate antiretroviral therapy in this population of people who were all male at birth and considered to be at high epidemiologic risk in this population in Peru. So I won't go over the whole study design, but it's essentially a screen, test, retest model where everybody is getting screened with NATs and serologies every month in order to be able to detect incident HIV infection. So Sabes step 3 was the step of 216 people who had been diagnosed either seronegative or last known negative test within 3 months in this study, who then entered the study with, again, incident HIV infections. Just important to note up front that this study was enrolling from 2013 to 2015. So this is prior to the treat all. So this was considered to be ethical at the time, and this study would not be repeated currently because obviously, as we just discussed, the guidelines have changed since then. But in any case, people were randomized to receive sort of standard of care antiretroviral therapy, either immediately on the time of their diagnosis on the same day, or to defer getting standard of care therapy by just 6 months. And the main part of the study I mentioned was kind of model the public health benefits and cost effectiveness of this, but I led sort of the clinical and immunologic outcomes of this part of the study. We'll also be I'll be using the term EDDI throughout this presentation. So that means the estimated date of detectable infection. It's this really cool calculator that's publicly available from UCSF, and we partnered with them. And essentially it takes everybody's testing history with all the different types of tests, Western blots, serologies, PCRs, and tries to calculate when somebody was most likely had acquired HIV based on kind of the aggregate and the uncertainty windows around all those tests. So in this study for the as treated analyses, we bucketed people between likely acquired HIV within 30 days, 30 to 90 days, or after 90 days. So we'll be using those. So here's the demographics of the study. We had 105 people treated immediately and 111 people randomized to defer treatment. As again, everybody in the study was male at birth of any gender identity, but because this was meant to look at this particular population in Peru, the ART was sponsored, so this was an NIH-funded study, but the study drugs were co-formulated and actually branded, I'm giving the generic names here, branded efavirenz or elvitegravir-based co-formulations, and the change in treatment was just based off of what was donated over time. And so anybody who was being randomized concurrently was receiving whatever was being provided, so not differential by arm. And again, everybody was enrolled in this part of the study prior to Peru adopting the WHO treat at all recommendations in 2016. And prior to that, because they were using CD4-based thresholds, anybody who had been randomized to the deferred arm could actually start ART immediately whenever it was felt to be clinically appropriate by their clinician if they developed an opportunistic infection or if their CD4 count came back and met the country threshold, which at the beginning of the study was 350 and by the end of the study was 500. So one of the just first sort of implementation kind of science outcomes of the study that's really important to note is that every single person of the 105 people who were randomized to be treated immediately started ART within 6 days of their diagnosis. And of the deferred arm, who were deferred to wait, 23% actually started early based on having a low CD4 count, which met clinical criteria by national guidelines, or had symptoms consistent with either severe acute retroviral syndrome or an opportunistic infection, what prompted their clinician to offer them early. Another 5% never initiated antiretroviral therapy, and another 5% started late. So 10% of people in this highly controlled study didn't start ART on time or at all if they weren't offered ART the same day. So I think that's kind of my first take home. The next clinical take home is that offering immediate antiretroviral therapy in acute and recent infection prevents opportunistic infections and acute retroviral symptoms. So if we exclude symptoms that are definitely not related to study drug or things like bacterial STIs that we don't think would differ by arm, we just look at people reporting infections, we see a strong effect of preventing sort of any type of infectious complication in people who started ART immediately. And then when we look at the intent to treat analyses, so again, immediate versus deferred arm, and we look at what I'm calling non-related events, so meaning events that aren't related to being an adverse effect of the antiretroviral therapy that the participant or their clinician attributed to study drug, we see that there are fewer overall adverse events of every type. And then same thing when we look at the different ART categories. So people who started ART within a month, with 1 to 3 months or greater than 3 months from their estimated date of infection, we see overall a decrease in all adverse events and then non-related events. Of course, the ART-related events don't differ because people are reporting events from ART. So next we'll look at the immunologic benefits of starting ART in primary HIV. These are violin plots. I don't know how I feel about violin plots, even though I made these, so I'll just say that. But essentially, it's sort of a density plot looking at the CD4 and CD8 distribution. So this is actually CD4 ratio, which was the one that we saw the most kind of important here because we're looking not only at CD4 depression, but also CD8 activation, which we see a lot of in early HIV. So overall, we see CD4-CD8 ratio kind of bottom out in this 1 to 3 month time frame after HIV acquisition. And then if we compare these different as treated groups, we actually see that if you look at the people who waited more than 3 months versus the groups who started within 1 month, we see that people's overall CD4-CD8 ratio is better after 24 weeks of antiretroviral therapy. So no matter when they started, they're all observed 6 months after starting. Their CD4-CD8 ratios are better. Their absolute CD4 was also better. And then we actually have data on a follow-on cohort called Merlin, which followed these participants up to 5 years. And if we look at 4 years, it's not exactly statistically significant, but we see that overall people's CD4 count and CD4 ratio is better and at best in the group that was treated within 30 days. Now, if we look at, this is PCA or principal components analysis. So we took 20 different soluble biomarkers from plasma and we compared them at the time of randomization, which is this essentially their diagnosis visit at the day they started ART. So that's either, at randomization or potentially 6 months later. And then after 24 weeks of ART. And the different colored dots are the kind of multidimensional axes of these 20 different biomarkers. You can actually see most clearly in the plot on the right that these groups segregate. So you can see that we have a difference kind of in global immune function as assessed by these soluble biomarkers. And there's a lot of distinctness. And the group that's actually the most distinct is the group that waited more than 90 days from their estimated date of acquisition to start ART. So this is important to see. When we look at kind of the within 30 days and 31 to 90 days, there weren't a lot of differences in that pairwise comparison, but the three groups are different from each other. These are just longitudinal changes in a kind of a different paper led by my colleague Tripti Gilada that looked at change in soluble biomarkers over the first 24 weeks. So this is essentially people who were treated versus not treated during those first 24 weeks. And you'll see that CD4 counts in the blue. So those are people who are under treatment. CD4 counts are zooming up. CD8 counts are going down. That's what we like to see. And then a lot of these markers of immune activation are coming down nicely in people during treatment and then sort of stable or not stable. And then you can see on the right-hand side, we also have viral load. So that's really important. And then in this study, there's a lot of use of alcohol and smoking as well as some other substances. And we can see that a lot of these inflammatory markers are also mediated by exposure to smoking and alcohol. Next is a cool sort of sub-project done by actually one of our medical students who was doing their III, if you're familiar with the kind of scholarly project for medical students. So we looked at the experience of having acute retroviral syndrome, which many of us are familiar with. She just looked at the incidence of these different symptoms that people have. So a high proportion of people had fever, pharyngitis, lymphadenopathy, kind of all of the things that we're familiar with. And then she stratified it a little bit differently. So within 30 days, within 50 days, and within 51 days, because this is not until time of antiretroviral therapy initiation. This is sort of from the estimated date until that randomization visit. And you can see that the people who were caught within 30 days had a higher prevalence and higher burden of symptoms overall compared to people as kind of further out when we met them. And then she also saw, and this has been shown in the literature before, that people who are experiencing acute retroviral syndrome also had a higher viral load at diagnosis. And why is this important? Because she also saw that people who experienced antiretroviral syndrome took longer to suppress their viral load or failed to suppress their viral load at all during the first 48 weeks of this study. But that's only in those who deferred ART. So in the group, these two Kaplan-Meier curves are stratified by immediate versus deferred ART. So the people who started their ART immediately, their acute retroviral syndrome didn't impact their ability to suppress their viral load, whereas people who wait, the people who had symptoms actually had a harder time suppressing their viral load. And then there are also the people who had antiretroviral syndrome were more likely to have their CD4 count bottom out below 350 within the first 6 months. So this is just even early, whereas people who started their ART immediately didn't have that drop associated with that. So the last question that we tried to answer, or at least that we have published from this, we also looked at microbiome and some other things that I won't share today, is whether earlier antiretroviral therapy during primary HIV influences how large the HIV latent reservoir is. So a really important concept for potentially future cure and ongoing inflammation and metabolic aging and all of these things with HIV. So this is data not from our cohort, but it's another first-year medical student summer project. Eva Shelton, who's now an internal medicine resident elsewhere, did it with our friend Dan Reeves, who's a math modeler. And we essentially plotted all known data on acute and primary HIV and reservoir. And so if you look, I think the key feature here is at the part C of this plot, you see this nice linear relationship between people whose reservoir was measured after 1 year of ART or later, and how the time between their estimated date of infection and when they started ART. And so you can see here that the earlier people start ART, the smaller their reservoir is. And then we went on to show this in our study. Oh, this fell off the slide. This was published by my colleague, Dr. Massanella, who did this with our cohort. But essentially, people who started ART in that early group, so within 30 days, had a quicker decline in their reservoir as measured by this tilde measure. And so you can see that their half-life of virus is 5 weeks versus 6.5 weeks. And then you overall see that the slope is faster. And these are just like looking at change in slope. So people's virus decays more quickly in their latent and their inducible reservoir the sooner that they're started after acute infection. So here's my summary. Even with closely followed randomized study, 10% of people randomized to defer ART started late or never. So this is, even more important when we see people in the real world that aren't being called by study coordinators all the time. So same day start really supports that. And ART and primary HIV decreases overall symptoms, including OIs and antiretroviral syndrome. I totally forgot to mention we had people that had shingles and oral hairy leukoplakia and extrapulmonary TB, all this stuff that wasn't seen in the immediate arm, seen in the deferred arm, just waiting 6 months. So that was kind of shocking, I think, to see just a 6-month wait having that implication. And again, improved short-term and likely long-term immunologic impacts. And those who started ART within 30 days of infection had a steeper and more sustained decay in their HIV reservoir measured out to 4 years. And then we're actually submitting this data to the WHO. It doesn't really change guidelines, but I think it furthers kind of the statement that in addition to what we know about people who have HIV of an unknown duration, that starting people in acute infection not only is beneficial for public health reasons, but is also beneficial for the individual person on both their clinical and probably immunologic function long term. And this will be something that we can't really study again now that the WHO guidelines recommend treating everybody. So here's my appreciation, most importantly to the participants, long list of collaborators who helped with this study. And again, the study was not designed at all by a pharmaceutical sponsor, but we received drug donation to help support this study that was funded by the NIH.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.